I'm a trauma surgeon by trade, and did a master's in public health at Columbia and was really interested in this implementation of new ways of doing things. And I found in public health the one thing that frustrated me the most was trying to figure out what that right thing to do is. What's the right thing to implement? And you could look at the literature and you could ask the experts, but if they knew, we'd already be implementing it. And so I was looking for a different methodology. And this is where I found design. So I took a 2-year research sabbatical while I was in my surgical training. So I turned a 5-year training into a 7-year training, and I spent 2 years working at this design firm. And it was probably the most revolutionary professional thing I've ever done, because it really gave me a tool and a framework to think about innovation and to think about what that thing is that you're going to do when you implement something. And so I'm hoping to give you sort of an overview of it, and then we'll share one example from work I did while at IDEO in China around kidney failure and dialysis. So when I finished my training and I came back to UCSF, I said, I want to start a design lab. And people looked at me and said, what is a design lab? And I said, I'm not sure yet, but we're going to do it. And so our goal is really to bring human-centered design to the healthcare setting, but to study it in a rigorous and academic way using public health methodologies. So we have a team of like 6 or 7 people. We swell over the summer. One of my colleagues is here, Katie. She is actually not in medicine. Katie is a master's of design, but is interested in healthcare. And so one of the basic tenets is we bring people who are designers but don't have healthcare experience, and people who are in healthcare but don't have design experience together to sort of cross-pollinate and learn from each other. So human-centered design has a long history. I'm going to cover some of this with quotes. It's sort of a philosophy, not a precise set of methods, although it does have a methodology. It assumes that innovation starts by getting close to users and observing their activities, and the basic tenet of human-centered design is understanding the users, and not just understanding the users or your subjects superficially, but even understanding and being able to put words to things they might not be able to put words to. So understanding their unmet needs or their challenges. So what is human-centered design? I'll just go through a little bit of a brief list here. So it's a methodology, it's a process that gives you sort of a structured framework to understand and begin to solve what some people call the wicked challenges, or the unsolved challenges. It embraces ambiguity, which is very hard for many of us in academia. It prioritizes the needs and the values of the users. It meets people where they are. So it doesn't try to make someone something they're not, but it understands what their challenges are and tries to design for those. It thinks and dreams expansively, so we encourage wild ideas, knowing that some of those wild ideas might not be able to be implemented now, but maybe in the future. It really focuses on rapid iteration, low cost, low risk, getting boots on the ground, doing things now and learning from them. And so you prototype rapidly, and then it also prototypes iteratively. So you build on designs as you go. So this is IDEO. Those 2 funny-looking jokers are the founders. That's Tom and David Kelly. They're brothers. And they started off in the 70s. They were both product designers out of Stanford, and they moved across the street, and they set up this little design shop. And they started by designing things that if you dropped them, they'd make a noise. So things. So anyone here have a laptop? So they designed the modern laptop. It's the grid computer up there. If any of you know the famous Steve Jobs quote, he's never used a consultant, that's actually not true. IDEO designed the first Apple mouse. They went on to design hundreds and hundreds, and probably thousands of things, mostly products. A lot of medical products, things for automotive industry, things for aeronautics. And then around the late 80s, early 90s, people started saying, you know, you're doing a really good job of designing stuff, but can you design systems for us? Can you design the untangibles? And they pivoted in that way. So human-centered design is starting to explode. It's growing across many different industries. It's always been well accepted in product design, in the tech world, even in aeronautics and robotics. But it's starting to permeate things like academics. So Stanford now has something called the D School, which is a school that teaches human-centered design. In development, so there's an IDEO.org, so a nonprofit, and many different nonprofits are using human-centered design in their work. And in fact, the IDEO.org nonprofit has an office in Nairobi. It's also starting to permeate healthcare. And so, as Aditya said, I just came back from a meeting where there are probably the 7 or 8 major hospital systems in the United States that are trying to figure out how to formalize the human-centered design process within healthcare. Our lab, Kaiser, which is a big health sort of conglomerate in the United States, the Cleveland Clinic, the Mayo Clinic, UT Austin. And then lastly, the United States government is starting to embrace human-centered design, which is probably crazy, but the Center for Medicare and Medicaid Services, so the government organization that funds all of the basically publicly insured people in the United States, is starting to demand that if we're going to design things, it's got to be human-centered, that we actually have to know what people need before we implement it. So it can build anything, really anything. So it built a community market in Oakland, which is a town near us, to address issues of economic disparities. It built an infant warmer for neonates born in Nepal, in rural areas of Nepal. It built an outpatient building in Austin, Texas, that has no waiting rooms. Right? Anyone who's a provider here, no waiting rooms. People check themselves into their own room. And it built a bunch of nail salons in Kenya to help educate women around contraception. So this is our process. The traditional human-centered design process is the 3 bits in the middle. So it's sort of, and if you Google it on the internet, there's a number of frameworks, 3 steps, 5 steps. But really, the focus is inspiration, so understanding users' needs, in-depth qualitative and observational research. The middle is ideation, so brainstorming, idea generation, and the last one is implementation, and this is an iterative process. We have expanded this to a preparation and evaluation phase because we're taking an academic rigor to this. And so when we start a design process, we think about not only like getting the approval to do the research, but what is the data, pre and post implementation, the data that we need to be collecting in order to show statistical significance at the end. If you think of it from visually, our process goes very broad when we interview and then gets narrow. When we brainstorm, it gets very broad again and then gets narrow. And then when we start implementing, we go very broad and then slowly narrow down to whatever the best solution is. So we start with interviews, and a lot of our work we do in Post-it notes, and sort of we fill the room with these ideas, and so that we can visually see things. But we interview, then we synthesize. We take these interviews, for those of you who practice public health, sort of around ground theory of identifying what the themes are. And then we develop prompts to brainstorm or idea generate. Then we actually brainstorm, and then we start prototyping and iterating. So this is a famous quote from Henry Ford. It might not actually be attributed to him, but what he said is, if I asked my customers what they wanted, they would want a faster horse. And that's true. I mean, Katie used Uber to get to the store today. Sometimes you think of these innovations and you think, 10 years ago I couldn't have said I wanted to dial up, to get on my phone and request some stranger to show up in their car and I was going to get in it and go to the store, but it fits a need. And if you'd asked me what frustrated me about transportation and taxis, I would have told you I don't know when they're going to come, I can't see them, I never know how long it's going to take, and Uber filled that need. So why human-centered design? If you think about really good innovation, it's got 3 components. It's got to be desirable, right? It's got to be technically feasible, and it's got to be financially viable. So if you have a really good idea, but it's way too expensive, it's not going to work. And if you have a really good idea, but you don't have the technical capabilities to do it, it's not going to work. But if people don't want it, it doesn't matter how feasible or viable it is. It doesn't matter how much money you throw at the problem, it doesn't matter how cool or interesting the tech is. If people don't want it, it's not going to work. And so human-centered design always starts with the desirability component. And the other key tenet is iterative prototyping. And if you look at sort of a bell curve of cost and time, the design world would say fail early and fail often. We don't say fail in healthcare, but you really want to start testing things early and cheaply, right? And identifying when things don't work, and then iterating before A, you have too much financial investment, or too much emotional energy, which happens a lot in the United States, and then you're stuck using things that just don't work, but people do it. So we're going to go through the different phases, and then I'll give an example. So we're going to start with inspiration. So human-centered design, you go from sort of an informed assumption, like you have an idea of what the solution might be, but then the process helps you really build a deep empathy and a profound understanding. So taking you from sort of assumption and inkling to like feeling confident in the fact that you understand these unmet needs and that you can design for them. So the process, it's ethnographic, so in-depth interviews usually last about an hour. We go for quality over quantity, so many of these projects, to get to sort of convergence of themes, you need about 15, 18 interviews, sometimes 20 if you're trying to include a big ecosystem. You want to include everyone involved, so patients, providers, government officials. And the interviews tend to be very unstructured. I mean, we have a sense of what we want to ask, but if someone takes us somewhere that's interesting, we're not going to try to redirect them, we will follow them there. And then lastly, and this is also something that falls outside of traditional public health, is we look for extremes, and you do use that in implementation sciences, but if you interview just the people in the middle who are doing okay, you're not going to learn a lot about either the workarounds that people have developed or the profound challenges they're having, because everyone's sort of muddling in the middle. So we really look for people who love something, who hate something, who are profoundly adherent, people who are never adherent. If it's something in tech, someone who are very tech savvy or people who are very tech naive. And so we really focus in a lot of time on subject selection for our interviews. So the goal of this is to understand people's unmet needs. And if you think of like an iceberg, right? So the explicit needs are on top. So those are the things people can tell you that they need. I need transportation to the clinic. Then you get to sort of the implicit needs, which are the things I might not be able to tell you, but the things you might understand by watching them. So they might say, you know, for example, we interviewed someone who was talking about medication adherence. And, you know, he said, oh, I just forgot to take my medications. And we did a little deeper, and he said, well, my son, my 16-year-old usually reminds me, and my son wasn't home that night. And so that's an implicit need. And then you start getting to the very core, which is around, you know, he's afraid of dying, and he's not really sure this medication is going to work. And so these interviews, you really want to sort of dig down to not what people say, and not even what people do, which sometimes they can't tell you what they do, but by observation you can see what they're doing, but how they feel, and what their sort of biases are. So how do we learn from humans? Observations, so in context observations, going to clinic, watching people do, you know, in their workflow, in context interviews, so in-depth unstructured interviews. We use analogous research, which is that we face challenges in healthcare that other industries face. And so what can we learn from looking at other industries? And I'll give you an example of that later in the presentation. And then empathy, so taking a walk in your shoes, their shoes. Can you put yourself in their position? We did an example of this at IDEO was we had people talking about medication adherence and for elderly, right? And so we had the pill labels, which are hard to read if you have poor eyesight, right? And if you have arthritis, they're hard to handle. And then we asked some of the people we were working with to put on goggles that made things blurry. We made the type really small, and then we made them wear really thick gloves and asked them to try to understand and get into these pill bottles. It gave them a profound empathy. So in the observations, the opportunity here is to look for things that surprise you. So what did you notice? What was interesting? What seemed ordinary, and then what seemed extraordinary? How had people worked around the system? What did you like? What did you hate? You know, how did their behavior differ than what they said they actually did? And what are some of the challenges you saw them facing that they couldn't even have told you about because they've been doing it for so long, they've sort of worked around them? And so I'm going to do a couple examples here. Sometimes, particularly as a clinician, I'd walk into a room and I'm like, I'm in doctor mode, I'm in healthcare worker mode, and you just sort of get to the point and you forget to stop and look around and like survey the room. And so we're gonna go through a couple photos here. So what is that? I'll start with, what do you see here? This is a design opportunity. What is it? So it's a coffee cup sitting on top of a trash can. So people are using a trash can as a coffee table. Now we see this in healthcare, in our healthcare setting all the time. People open sterile gloves, they put equipment on a trash can because there's not enough spaces. And so that's a design opportunity. This is another one, this is going to be hard to see. So this is peritoneal dialysis in China. And what you see here is that's an alcohol swab, the package of an alcohol swab. And so this individual he's very concerned about sterility, and these are the connectors. So he's taken and wrapped the package, not the alcohol swab, the package of the alcohol swab around the connecting site to make it sterile. Right? We watched him do this, and that's how we realized that sterility in environment, the perceived sterility of an environment, mattered a lot. This is from work I did in Kenya. So what is this? Makes your wheelchair, right?
Right, yeah.
That's a brilliant design, right? That's taking things that you have readily available and co-opting things that already exist. You could think if you were going to design affordable wheelchairs, you could take things that already exist and develop a kit in order to cobble those together. They had hacked the system for us. They designed something interesting for us. So in context interviews, so you always want to start with empathy, and so really getting to know the individual. You know, who is this person? What makes them tick? You ask about process. Tell us about an example. Ask about extremes. Tell us about something that was really hard. Tell us about something that went really well. What are your challenges? If you could redesign this workflow or this system or your disease or whatever it is, what would it be? And then ask them to show you what they do. And another couple interesting tools you can use are either giving them, journey mapping, so asking them to mark out steps they take. Card sorting, so giving them picture cards and asking them to sort things either by priority or as a way to describe their workflow. And the last one is sacrificial prototypes, and this is scary for a lot of us. That is, you, as we said, you come in with an informed idea. You think you have an idea of what some good solutions might be, and so with human-centered design, you put them on paper. You make a prototype of them, and you bring them from the beginning of your project and say, what do you think? And many people think, well, they'll tell me they don't like it, or I might be wrong, and the goal is to be wrong, right? Because if they tell you, oh, it's nice, that doesn't get you very far. If they tell you what they don't like and why, that gets you to better design. So bringing in sacrificial prototypes and saying, what do you think about this? Oh, you don't like it? Great. Why? And how would you change it? And that can be an incredibly powerful tool as part of this sort of need-finding process. So we're working on some TB adherence with Adithya here, and I just want to start with, so if you were going to go and interview a patient, what would you ask? Anyone? I'll call on you, Adithya. You should know the answer, but what would be what are some of the questions you start with?
How often they take their medicines? How do they remember to take their medicines?
Yeah. All that stuff.
How it makes them feel? Do they have any side effects?
Yeah. So that's the last 10 minutes of the interview for human-centered design. So we start with something around like, where do you live? Well, it's not wrong, but it's like, where do you live? Who do you live with? What's your average day look like? What do you look forward to in your day? What are the things that you dread in your day? Do you have a phone? How do you use your phone? So we tend to ask the medicine questions, the medical questions at the end, right? Because what we're not looking for, we're really not looking for, oh, I take 2 meds and they make me feel sick, and at least with TB, we're looking for like what motivates you, like what are the challenges you face, and how can we design for that? How can we design the environment around you? Because we're not going to change the fact that you're going to take meds twice a day, or once a day, or that they're 4 pills, or they're big. At least not in this project. So we want to know who you are, what your environment's like, and how can we make you more successful. So analogous research, so this is a trauma bay, and in a trauma bay you have an individual come in, multiple people work on that at the same time, and the goal is to get them in and out as quickly as possible. And so a powerful tool is again to think, there are other industries that do something similar. What can we learn from them? So I'll call on Katie, she sort of knows the answer to this. What would be a good analogous for a trauma bay?
Let's see. Pit car. A pit stop in like NASCAR, where they work really fast to change the tires and stuff.
Okay. So anyone know NASCAR? I don't really watch, but the car comes in, multiple people work on the car, and then the car gets out. Because right, The pit is not a place to stay. The trauma bay, not a place to stay. So what did we learn? We learned that they were able to be efficient and get things in and out because of redundancy of equipment. So an upfront cost, and everyone had a toolkit with everything they needed in it. So you have maybe 3 drills or 4 drills. But the efficiency was that everyone had what they needed, so you could get the person in and you could get the car in and out. And if you watch how our trauma bays work, there's one set of gauze and chest tubes, and they're all on one side, and things are getting passed to the patient. It's inefficient. So empathizing. So how might you understand the patient experience? And this is something we did. Be in their shoes. So lay on the bed and roll through a hospital. So what do you think that experience is like? I bet you it's the same across the world. And I'll tell you what it's like. It's that, right? Yeah. It's that. It's ugly tiles with stains with lights. Many hospitals have nice marking and signs. The hospital we work at doesn't so much, but you know, like wayfinding, right? To orient patients, to orient people, but not patients, because patients are looking at the ceiling. Right? And so they're on medications, they're sick, they're delirious, they're in pain. And this is what they see. We spend a lot of time reading signs for everyone else, but no one's thought about what they see. And that was a big moment when we actually put ourselves in those shoes. This is from Inle Lake in Myanmar. So going home with somebody. So this is how people live in Inle Lake. They live on, this is a multi-family living domicile on a lake. There are no stairs, there is no land around them. And this is how they get there. That's how they row. So one person stands in the front and he uses his leg to row with a single oar. That is basically the water taxi. So think about care, providing care, accessing care if you're elderly. How you get in and out, the climbing, the scrambling. So now that you sort of have a sense of what these unmet needs are, how do you make sense of it? And so turning these sort of insights into like a point of view. And so this is a good tool. It's user need insight. So you could design for a person. You could take an archetype and say, this is Joe, right? Joe is 75-year-old living with HIV, tuberculosis, living alone. And you could say, Joe needs a reminder tool because he lives alone. Right? Or you could say, you could focus it around a type of person. So patients or patients with TB need whatever it is they need for this reason. Once you've developed a point of view and defined what that need is, then you turn it into a question that can be used to brainstorm. So how might we? Can you say no to how might we? No, right? How might we? That's not a yes/no question, right? So, and it's just possibility. So how might we? And then you fill in the verb or description of what you want to do, so that the user does feel has something. So you might say, for example, what we've been working with TB. You might say, how might we destigmatize tuberculosis so that patients don't feel afraid to share their disease process? This then falls into ideation. So this is where the brainstorming happens. And brainstorming, if you look at the internet, that people will say it's horrible, it's wonderful, but brainstorming is an art. It's something you can't do for more than 10 or 15 minutes at a time because it's exhausting. And you get a group of people, and if you can get a diverse group, that's great. And you put one of those how might we questions up. And then you spend 10 to 15 minutes asking people to generate ideas. The rules are, you have to defer judgment, so there will be bad ideas or not feasible ideas, and you can't judge them, which is very hard in healthcare. You go for quantity over quality. So the idea is to explore every tenet, every possible tentacle. If you don't like something, you say yes and, or if someone else's idea, they have a great idea, and you say, oh, would it be better if you say yes and, how about we add this? You show, don't tell, so you try to illustrate or draw or wireframe or sketch because it's easier to talk around things than it is to draw them, so it forces you to start. It's the first step in prototyping, and then you take turns, and basically it's a small group of people around the room saying, oh, what if it was a phone call, what if it was a visit, what if it was and you just start building. Eventually it peters out. That's what it looks like. And these are some of the things, so it doesn't have to be pretty. And these are some IDEO ringers, so that actually the drawings are a lot nicer. This is Dennis. But, you know, just putting a label on it and making some boxes and arrows. This will generate hundreds of ideas, and they will cluster around themes. So for a perinatal care project we worked out, trying to improve the experience for pregnant women, one of them was a sense of isolation. So we had a bunch of themes around community centers, community building. One was around transportation. So we had a bunch of different themes around transportation. And so eventually all these hundreds of ideas tend to coalesce around a certain number of themes, 10, 12 themes. So then it comes to implementation. So what is a good prototype and how do you get to good enough? With implementation, you want to design early. You want to start testing early. So they have to be really low fidelity. And so they can be as simple as a storyboard. So actually just sketching out. So here's the workflow. Okay, so the sputum sample gets collected here. Then it goes to here. And then it gets sent there. And then it comes back. Well, how do we notify the patient? Okay, so just actually putting it down on paper. Another one is if you're developing technology is to, or information tools, handouts is to wireframe it. So you don't have to make it perfect and wordsmith. You just sketch it out. This is what it looks like. This is what it will say. One of it is to act it out. So with workflows, actually acting out what that exchange is like. If you're working on education or outreach, what is that exchange like? If you're going into someone's home, what is that exchange like? Well, let's act it out. Well, that didn't feel so right. Let's change that. And the other is if it's actually a product, something if you dropped it made a noise, you build it. And so this is tongue depressors, paper plates, disposable plastic masks, and clay. And this is a prototype for a community center that was built for our perinatal care project. So it's iterative. So test, refine, and then this is where we start to get into the science of when you start to study this. When do you get to good enough? So I have a couple sort of ideas around this. One is the 1-10-100 rule. So when you're prototyping something in the early phase, one idea can't cost more than 10 hours of a person's time over a month, or $100. When you are testing to see, well, is this working or not? It's very qualitative. So qualitative feedback, observation, are people using it? Do they like it? You can set timelines. We're going to do it for 1 week. We're going to do it in one clinic. We're going to do it for 1 month. We're going to do it with one person. Then you have tested, hopefully you've tested a couple of these ideas, and then you end up having to choose. And that's when you implement and study. And so one of the questions Aditya always asks, and one of the weaknesses of human-centered design, I think, is what do you choose? How do you know you explored everything? How do you know you had the right thing? And that's when it comes back to frameworks. So one of the tools you can use is the behavior change wheel. This is very founded in implementation sciences, not used in human-centered design, but I think in the academic, as we try to push human-centered design into the academic realm, something like this would be necessary. Another is to go back to the desirable, feasible, viable, right? Great idea, people want it, too expensive, not gonna work. So we often say, here's what the future looks like and here's what we can do now. And the last, which is a really powerful tool, is mapping it back to a journey or a workflow or a process, right? So let's say for the TB example, you get a diagnosis, you're in the intensive phase, then you're in the continuation phase. What is that experience like? Okay, we want to go to diagnosis. We want to go before diagnosis to awareness. We want to focus on the transition from the intensive phase to the continuation phase. Or even more, we want to focus on the phase when people feel better, right? So that the relevance of their meds is maybe not so obvious to them. So that's human-centered design in a nutshell, and I will go through, we have about 20 minutes, I'll go quickly through a project I worked on in China. This was as part of IDEO, and we were trying to build capacity for dialysis in China. And I'll talk a little bit through the process and some of the ideas, and then at the end, what we wanted to push forward. So this is about peritoneal dialysis in China. So there are about, soon in the next, 2 years, there'll be 1 million people living with end-stage renal disease, so which means they will die if they don't get either some sort of dialysis. The majority of them go through hemodialysis. In the United States, we will dialyze people 3 times a week, but because there's a limitation of beds and machines in China, they dialyze people twice a week. And Peritoneal dialysis was an ability, doesn't require a machine or chair, its ability to do dialysis at home, is not very popular. Because of the limitation of chairs in dialysis units, and because peritoneal dialysis is not all that popular, about 400,000 people die every year. So our goal was to say, well, if we can't change the number of chairs and beds immediately, can we expand peritoneal dialysis? Particularly relevant in places, rural areas, where they can't reach dialysis centers in the big cities. So how do we understand? We were a group of, we had half our team was from China, but living in Shanghai, not people who grew up or were raised in the rural area, and the other half were Americans. So how do we understand what their needs are? So we did the human factors research. We started the kickoff meeting sort of to align all of the stakeholders. We did 34, so we exceeded our low quantity, high quality interviews. So we did 5 internal stakeholders, so people ran the peritoneal dialysis sort of work there. We went to 13 patients and family members and 16 healthcare workers. We did 3 home visits. We did 2 observations of people doing peritoneal dialysis, one in a hospital and one at home. And we did 1 observation in the hemodialysis clinic. We went for sample selection, we went for extremes. So we looked at, in China, the hospitals are varied by tier. So tier 1, tier 2, tier 3. And so the tier 1s are in the big cities, and then you get more rural. So we basically went to 5 different centers throughout China along the western seaboard. Some of them big urban cities and some more rural. And we looked for extreme users. So people who are doing peritoneal dialysis in a very small apartment in a very rural area, to people who, in China, there were some people who actually moved into a hospital and lived there and got their dialysis there because they were government employees and the government would pay for it. So just some pictures. So this is our gentleman who wrapped he's getting his peritoneal dialysis in a clinic done by a nurse. And this is the gentleman who wrapped the alcohol packaging around his connector. So even being in a clinic and a hospital being done by a nurse, he still felt like he had to do something else to add to the sterility of it. This is a hemodialysis unit, and then we went and visited homes. And this is, for this individual, this is the majority of their home, so it's a bed that they sleep on and eat on, and there's not a lot of space. And peritoneal dialysis comes with boxes and all the liquid equipment, so what we realized is there's not a lot of room to store that in this home. And then we used interviews, but we also came in with some sacrificial concepts and did some card sorting. So we had a number of insights, and I'll just read a few of some of them. And this is interesting because this sort of transcends disease and geography. In that, like, to patients, this diagnosis marked the onset of certain death. And we've actually heard that same thing with some of our TB patients. And some of them regretted ever going to a clinic because now they were diagnosed and now they moved. When faced with life or death, people choose the thing that is most familiar to them. So they would always choose hemodialysis, and some people would end up dying in the attempt of trying to get hemodialysis because they didn't want to get the other thing, the less common thing, which was peritoneal dialysis. Providers in China prescribe what they know and are comfortable with, and there were a lot of providers who weren't comfortable with peritoneal dialysis. And there's a really interesting cultural context to this in that there's a fair bit of paternalism, and patients will pay providers to get care, but there's also expectation that care is good. And there have been there are providers in China who have been murdered by families who weren't happy with the outcome. And so seriously, so there's a lot of stress by providers to choose the right thing. Patients didn't trust themselves. They didn't feel like they would be capable because of doing peritoneal dialysis at home, because medical care in China should be done in a hospital, so they didn't feel comfortable doing it at home. And then the sense of hospitals are clean, but homes are dirty and not sterile. And then lastly, and this was a really interesting, that hemodialysis comes with a community, because you go to a dialysis center, but peritoneal dialysis is done at home, so you're isolated. So we then led a design workshop, and these sort of workshops or moments to bring everyone together are really important. And I'll talk about that in the next slide. But we led a workshop with 26 people, and we came up with 12 promising concepts. And I'm not going to go through all of them, but I'll go through a couple of them. So So the importance of workshops, so we lead off every project with a workshop, bringing everyone together, making sure that all their ideas are aligned, hearing what they think the problems are, what those assumptions are. But after the inspiration phase, when you have a better understanding of these unmet needs, it's really important to bring people back again. One of the reasons is oftentimes you have to reframe the challenge, right? That what people assumed was going to be the answer, what they assumed was the problem, is not actually a real problem. The second is to create empathy, so align everyone around what is the plight, what is the issue we're dealing with here. And the third is to present all those insights and make sure that you're on the right track. The next is to get buy-in from your advocates, but even more importantly, your skeptics. And that's one of the things that most people don't think about. The person who is going to be most suspicious and most skeptical of your work should be invited here. Because you can then mine their brain trust, make them feel involved, and make them feel like they're a part of the solution. So here are some of the things we came up with. So clean room in a box. So can we, and because the sort of sterility was a little bit around optics, right? The wrapping the alcohol swab, and that peritoneal dialysis can be done safely in almost any environment, right? So can we build a toolkit of something that people can put up in their home that makes it feel sterile? It's an add-on, not necessary, right? It's an extra step, but it is an extra step that would address a very real barrier, right? The next is making people feel empowered with doing the dialysis. So oftentimes, if you have people having to do something, it is the thing they're working on and then an instruction manual. So we looked at, can we actually put the instructions on the packaging? So you're not comparing the two, but you're actually, the packaging is actually, the bag is actually telling you how to use it. The next, and this was the most interesting, is addressing the providers. So they want to feel like experts, and we sort of spoke about the risk of them making bad decisions, and they were embarrassed to say they didn't understand. So can we make a journal around dialysis that looked and felt like an expert's journal, but really was educational, and help them learn more about it? And lastly, and I thought this was really interesting, is can you develop a decision hotline that the provider can call with the patient to discuss the options? So this takes a little bit of the responsibility off the provider, also makes them feel like an expert, gives them an extra tool, and in the process they learn and they get more comfortable. And as they get more comfortable, they don't have to use this as much. So we had, as I said, about a dozen ideas, and those were just a few of them. And so now we're at this point where we've got a dozen ideas, so what are we going to implement? So you could go back to the behavior change wheel, you could go back what's technically feasible, what's viable, what's desirable, or you could try to map them to a journey. And so we mapped out a journey. And so this is, we have on the top, this is the provider journey, and this is the patient journey. And it starts with not understanding peritoneal dialysis and feeling no capabilities. So if you think about the stages of change, to actually being ready to start learning about it, to then learning about it and then starting to feel comfortable prescribing it. And that's where it meets the patients. For the patients, it's, I feel crappy, but I don't understand that I have kidney disease, to, oh my gosh, I have kidney disease and I'm going to start learning about this process, to starting to care for your kidney disease, seeing doctors, to making a decision, to doing the dialysis, and to doing it comfortably. So two of the things that we felt were desirable, met an unmet need, feasible at the time, and viable. One of them addressed the provider and one of them addressed the patient. And so when we finished this project, this sense of this hotline, so it doesn't address the upstream need, that there are a lot of people who just don't do PD and they're not going to do peritoneal dialysis and they're not going to prescribe it right now. It met those people that are somewhere in between. They're trying to get comfortable using it. They want to start having the conversation. If you're looking at the stages of change, they're ready to make a change. And this is a tool for them to help them get over the hump, to take some of the responsibility off them and to start implementing. And so we could start converting people to be more confident providers. So if you look at the patient journey map, for the patient, there were a number of things we could do. We could develop clean rooms, but that, that was going to be financially expensive and take a lot of time, and there's a lot of patience. So a simple thing is to just change the packaging, right? You're already printing it. Can you change the packaging to empower people? So the reality is, this is how you get to idea generation, and this, I think, is the beauty of human-centered design. We handed this off. And I'll be honest, I haven't seen I'm not sure if any of these things were implemented, unfortunately. That's one of the problems with doing consulting work, and which is why I wanted to bring the work that we do in-house to healthcare so we can actually implement these things.